So certainly the title of the panel today was called Accessing Healthcare, but I certainly think we can answer a variety of questions. We'd encourage you not to have specific questions about your own personal health. I think those would be better addressed to us afterwards, but certainly more general questions of any topic would be, perfectly fine for us to attempt to answer. So I'll go through the ones which have been submitted and open them to the panel. And then if you have other questions as we're going along, please raise your hand or hand them to Rosemary and she can just bring them up. So the first question is a question I knew we were absolutely going to get, and I'm happy I'm moderating and don't have to answer it. So, do we find more doctors more open to the use of cannabis as a natural replacement or alternative to harsh pharmaceuticals? What about its use for sleeping or potentially the use of oils versus nighttime Advil? So, panel members, please.
So I'll take that one to begin with. I think the short answer is I think you will find people more open to it, but there's also some cautionary notes. Just as an aside, what day is today? Saturday. On Thursday night, we had a sectional journal club, and the topic of discussion was cannabis, medical cannabis. And for those of you who may not know, there was just an editorial in the New England Journal. I think it was from last week's edition. And that was the topic was, medical cannabis, and there was sort of a debate there. So we debated that as well. And, one of the things that we looked at was, well, how many of us were actually already prescribing it in certain instances? Most of us were, and that will include me as well. You should have given me a look.
No, I didn't know. In Alberta, you have to have special permission to be able to prescribe medical marijuana.
So the cautionary notes, though, and we're mostly using it for chronic pain and sleep. And that is where the evidence is, that it can be helpful there. And if you look at the counterbalance, like what else have we got for chronic pain and sleep? We've got opioids, and I don't think I have to say anything more about that in terms of all of the issues with opioids. There's anti-inflammatories, which many people have contraindications to and, work marginally. Same for acetaminophen, Tylenol. The more and more negative studies are coming out about gabapentin and the gabapentinoids in terms of their effectiveness for pain. So you're sort of going, okay, what do I got? And so given that scenario, and given the evidence that we do have, how can you not suggest or agree to a trial of cannabis as a pain medication? I think we universally agreed that in terms of safety, we all have some concerns certainly about smoking because of lung toxicity and including vaping. And that is, I think, most physicians, we like to have some idea of what we're prescribing. What are the benefits, what are the side effects? And we are really short on information on cannabis, and that's where we get uncomfortable. And so we have concerns about, the inhaled forms, and most of us are much more comfortable with the oil. And most of us can point to success stories where patients have clearly had benefits in terms of pain management or sleep improvements and been able to use less of or have less of other things that are more toxic, like opioids, or just have better quality of life.
Good question. Interactions with current medication. If the cannabis finds that it's useful for sleep aids or pain, does it counteract our current drugs such as prednisone, other drugs?
Maybe you could just repeat the question so everybody can hear. I wasn't sure if everybody.
So the question was whether there's any interaction between cannabis and other medications that a person might already be on, like prednisone or other lupus medications. And for lupus-specific medications, there's no known interactions. Obviously, there could be interactions between cannabis and opioids or other sedatives or hypnotics. We have to be very careful about that. I think the other thing I should have mentioned is that sometimes cannabis is seen as a replacement for prednisone or mycophenolate we do not have that information there. So that's where a real cautionary note comes in. If someone with lupus or rheumatoid arthritis wants to treat all of their disease with cannabis, we don't have any information to suggest that that is a useful possibility.
I'd like to add, if that's okay. So from the pediatric perspective, we've essentially come out from the Canadian Pediatric Society and all the pediatric groups that because the brain is still developing up until at least 25, we're generally not recommending cannabis because of potential psychotropic effects.
And I'll add too.
Yes.
You know, it just hasn't been around long enough to really know enough about it. And, you know, as it was pointed out, we don't really know the dose. So if you're just smoking joints, we don't know the dose you're getting, so we can't recommend going up or down. The research still needs to be done, but, you know, we've all seen people who have benefited from it and maybe been able to be off medications that are more toxic. But everybody has an individual sensitivity too, so that some people who wouldn't get a side effect, other people may get a significant side effect like hallucinations or psychotic type symptoms. So it's something that people can and may try, but you know, there's still a lot to be learned about it.
Yes, go ahead.
I understand that there's, in Alberta, there's a rheumatologist that can prescribe cannabis right now.
So I'm not the best person to really answer this. I really don't know this literature. You probably know better.
You can go to, there are clinics that will prescribe it. They have physicians there. They're not rheumatologists. I don't think there'd be a rheumatologist, but I know one where there's GPs, one where there's a psychiatrist that's prescribing, and they can do the dosing, you know, in terms of recommendations and do follow-up.
Right. Okay.
So that's a good one. Of course, now you can just go and buy it loose leaf, right?
Yeah.
And but then again, you don't exactly know what you're getting.
Well, the other thing about, again, and every province is different, and we're just figuring out this whole legalized thing, but at least in Manitoba, yes, of course, there's a bunch of, now there's marijuana storefronts, and you don't need a prescription, anybody can go in there. Mm-hmm. But what they don't actually have is it's the CBD oil. Like there's the THC, which is what gets you high, and the CBD is what helps with pain and sleep and possibly inflammation, the part that we don't know. And the storefronts, at least in Manitoba, don't really have the CBD products. When we send somebody with a prescription, they're going to a different place, and I think they have to order it and it comes online. So if you're walking into your store, your generic store in Manitoba, I don't know if it's different here, you're more likely, what kind of high can I get with this? Like, it's a different question, it's a different group of products. So if you're looking for it for pain and sleep, that is a different, I'm not sure you're going to be well served by just walking into a storefront.
Okay, we'll switch to a different topic. You may want to come back to this one a little later. So we have a specific question here for you. Okay. And this is that we find diagnosis may be different between ER sites. Do you suggest ER shopping if until the right solution is found, or do you think that different ER sites specialize in different things? For example, the Rocky View is known for its ability to deal with urological issues.
Mm-hmm. Well, I think if you're properly worked up, no matter what ER you go to, they should be able to provide a diagnosis. In Calgary, of course, the Foothills has most of the tertiary specialty programs, but any hospital emergency will be able to call and consult a specialist who's on call at 24 hours. So theoretically, you should be able to go to ER and get yourself worked up and the proper diagnosis. At times they may not be able to make a diagnosis, and that's why there should be some follow-up recommended, or whether it's testing or treatment or a referral to a specialist. But it's not necessarily helpful to, if you don't like what you hear in one, go to another. unless you feel like you weren't properly managed, like if you didn't like your interaction with the person, if they were really rushed, they rushed you through, they wouldn't answer your questions, then I think you should seek a second opinion.
Can we add to that? So certainly from, I can safely say from a lot of us, having to deal with doctors, and for the most part, the physicians that we've seen in various capacities are fantastic, and they take it to heart. But when there's situations where the case became a little more complicated, because I think a lot of lupus patients, of course, have other ailments, tied with it, and what, at least from our personal experience, sometimes is that when a physician can't figure out what the problem is, they just automatically fall back, it's lupus, and then they just walk away and just say, okay, well, you talk to your rheumatologist and be done with it. And so my question is, how can we better maybe work with the attending physician to say, hey, look, you can't just expect that, oh yeah, just because you don't have an answer, automatically it's just lupus.
Mm-hmm. Well, I think that if you're not satisfied with the response you get, then you should seek either more tests or go for a second opinion elsewhere. Yeah, I mean, they should be able to tell you why they don't think it's lupus. They shouldn't automatically, assign it to, well, it's caused by lupus. It may be, but I don't know if you remember from my slide, there's a lot of things besides lupus that cause illness,
Sure,
right?
very much so.
And so that's part of the challenge is figuring out, is this lupus or is it not lupus? And that's where the testing comes in. So the physician who sees you should be able to make a rational decision or comment as to why they think it is or why they think it's not.
So I think just to follow up on that question, more along the same line, is how do you get your family physician and other doctors involved versus having to go to the rheumatologist with everything? So how do you involve sort of other caregivers in your care? Don't know. Shall I start with that one?
I can start with that as a GP. I think you should have a GP who's interested in you, so that if you're going to a place where they're just rushing you through and giving you a prescription, the chances are you're not going to get the quality of service that you deserve. So the first thing is you should have a GP that's interested in you and learning about your condition. All right. Early on in my career, I ended up having a lot of HIV positive and AIDS patients, and I didn't know anything about it back in the early 90s. So I went off and did some, training. So you should have a physician who's willing to learn about your disease so they can, treat you properly.
I guess just to follow up on that, I mean, that's fine for people who are living in large urban areas, but if you're in a rural area where there's few family doctors, clearly it might be more challenging to find a doctor who has a particular interest in the condition that you have.
That's true, but they should still be interested in you.
Yes, they
and
should.
They should be willing to learn and study about your disease because they're going to be treating you. For sure.
And I think from our end, I mean, what I try to do is then also provide some education back to the family practitioner. A classic example that was raised by you and I think by a question about the higher risk of heart disease in lupus, which most people who have lupus will eventually hear about, but many family practitioners, if they've only got a couple of lupus patients, won't really know that this is something they need to be careful about and be extra strict in terms of treating it. And so I can send that back to them saying, by the way, yes, I know the blood pressure is only a little bit elevated, but in a lupus patient, that's really too much, or that, and here's the reason, and blah, 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 and hopefully provide some education back to the family practitioner then, who can also then be aware, oh, this is what I'm actually trying to do, and this is why. And hopefully, if we get a dialogue back and forth, that can help a little bit as well.
And the other thing I would add, I think it's important for the specialist to be available for the family doctor. So certainly, if the patient goes to the family doctor, has a concern, and the family physician is not quite sure, is it lupus, is it not, that, the family physician knowing that physician can contact the specialist really at any time and discuss the case over the phone, I think is very important, because often, just by speaking with the family physician, you can provide a little guidance and save that patient a trip to the lupus clinic. So I think that's very important, that two-way dialogue. Yes?
Question about trying to liaison amongst the specialists, each other. I'm trying to understand, when you have other specialties involved, like neurologists, gastroenterologists, it is deemed to be lupus related. Is it reasonable to assume those symptoms of those different specialties would still be managed primarily by a rheumatologist, or is it specific to what the symptom is as to whether you continue care with the neurologist, with the gastroenterologist, with the hematologist? And how do you get all of these physicians on the same page? Because other than their consult letters going back and forth to each other, there is no communication, and you have multiple systems involved, and you're trying to advocate for yourself, and you're saying, well, that's not what was discussed, and there's a lot of back and forth, and I found that to be one of the biggest challenges that I've been struggling with, and I am somebody who gets on with medical records, and get all the council reports, make sure everybody has everything, but to have that, there's still so much disconnect going on.
So the question was in terms of coordinating the care between a variety of specialists. So I think in the ideal world, what you basically would have would be the lupus physician would have a multidisciplinary clinic. So the lupus physician may bring in the nephrologist for a day, or bring in the hematologist for a day, or bring in the neurologist for the day. Then the patients with these issues would come to the clinic. So then at that point in time, the two physicians would discuss with the patient and the patient's family the best management for the patient and the patient's concerns. Now, certainly, this exists in some urban centers, and we are starting this here in Calgary because I think that really does offer the optimal management to the patient. But short of that, it is a challenge. But again, I think the communication, being able to just pick up the phone and call the hematologist involved in the patient's care, or the neurologist and so on, not just relying on the consult letters, but actually having a dialogue. If you're concerned, when the patient's there in the clinic, page that particular physician at that time and discuss the issues around that patient. Because I think that communication is absolutely critical.
So it's normal for these other specialists to still have to be involved.
Yeah.
It's not just a little bit down on the
No, I think it's important that these specialists be involved, because certainly, for example, if you have new kidney disease, it's important that the nephrologist and the rheumatologist talk about what would be the best treatment for you. Medications may need to be changed a little bit at the beginning, and so on. And once you're on a stable dose of medication and you're doing well, then perhaps a rheumatologist can follow that, can follow you in the long term and just bring in the other consultants if there is an acute event or, something goes wrong. But I think at the time of initial diagnosis, when there may be symptoms involving many different parts of the body, I think bringing in those particular specialists is what will give the patient the best care.
I just want to add to that. I was going to say that I think you as the patient are your best advocate. And if you need your family to help you, be it your partner, your children, your parents, whatever, that's fine. But you are the strongest advocate for your own healthcare, because we're busy and seeing lots of people, and sometimes we don't necessarily give 100% to every person, even though we want to. And if you come back and say, I think we need to talk about this, that's completely reasonable, and we need to be responsive to that. That's one thing. Second thing is find the best lupus doctor that you can. So there are a lot of rheumatologists, and I think we're all pretty good, but not everyone takes care of lupus. It's very complicated, as you all know. And if you're able to find someone who specializes in lupus, it's going to take you, to the next level, if that's a possibility. And if you're living far away and you can't get to that person, there's a shared care model where you're seeing your rheumatologist who's close to you, and then once a year you can go see that lupus specialist or something like that, where you have a shared care model so you can get that care. And then sometimes we do, for example, say one of my patients has a low blood count of some sort. And I think it's probably the lupus, but I'm not 100% sure. And I just want another opinion from the hematologist, say from the blood doctor. And I'll send that patient and they'll get a consultation and I'll speak to that person or I'll get a letter back and they may not need to see that person again. So sometimes there is, and it's not necessarily a dump on the rheumatologist, but sometimes there is that one-off and sometimes there needs to be that ongoing shared care.
And I'd like to give a plug for primary care again, because I think that's why, you know, it's important to have a family physician who's interested in you, because not everybody lives in the city, they don't have access, and sometimes they can't get an appointment very quickly to see a rheumatologist, even for follow-up. So if you have somebody who's interested in you and is willing to, you know, at least, as I say, quarterback and have you referred to the appropriate area or help you assimilate all those different opinions you're getting from different people, I think that's crucial.
Yes.
So in the beginning, when you're newly diagnosed, people have a whole litany of complaints and symptomatology. And so when you have all these consults with all these specialists and you develop those symptoms, who should you access first? Because if you do you divide up your symptoms based on what you have? You call your immunologist and then you call your gastroenterologist. Who do you call? Do you call your family physician first and have her communicate with the various specialists? Or call the rheumatologist's office first? Like, how does this work?
Well, I'd be interested to hear what you all say. So I don't know if you all heard the question. The question was, when you're newly diagnosed and you have a variety of symptoms and you have a variety of specialists involved in your care and you develop a symptom, who do you call first? Your rheumatologist, your family doctor, or the specialist who you think may be best able to address that particular symptom?
So I guess from my point of view in that scenario, I would probably say the rheumatologist. That's the person who's overall going to be looking after the lupus long term, you know, both whether it's kidney lupus or neuro lupus or joints, sort of the umbrella. And so that often can be the first line of questioning. And then if the rheumatologist feels, gee, I really need some input from the neurologist or the gastroenterologist, then that's a reasonable way to go. That, of course, assumes that you have access in terms of how easy is it for you to get hold of you. That's, I mean, if you've got a great relationship with your family doctor, then maybe that should be the first point. If you can't, if it's easier that way, if you can find that person easier. But, you know, I mean, I'm the first person to say I don't think this often works very well. We haven't got our heads around a model that works very well for the shared care, and there's a lot of reasons for it. But this, you know, the lack of communication or how to communicate is an extremely common problem, and it's very legitimate that it's not working as well as it should, in my opinion, and it's really hard to figure out how to make it work better.
And it's also very difficult to self-refer yourself to a specialist. You know, the way the system is, you generally have to go through your family doctor to get a referral. So, you know, you may have been diagnosed in your family physician's office, or perhaps not. Maybe you've been referred to the rheumatologist. Really, a lot of it depends on the comfort of if you're seeing a primary care doctor, what is their comfort level dealing with it? Like if you're their only lupus patient, then, you know, you should probably not be managed primarily by them. But, you know, they certainly would be able to participate in your care, because not everything is going to be related to lupus, right? You still have to see for other reasons.
And, you know, I would just add, it's certainly very challenging so far. I'll just give a couple of examples. So, you know, if you've been newly diagnosed with lupus, and for example, your major problem, you got a little bit of arthritis, but your major problem, for example, may be low platelets. And it's your hematologist who's really been managing the low platelets. So then if the the hematologist is the one who's calling you and saying your platelet count is low and so on. So in that situation, if you have a problem which you think may be related to the platelets, then it might be appropriate in that circumstance to call the hematologist, because that's the one who's been specifically prescribing the medications for that. Or similarly, if you've just been diagnosed with kidney disease and it's your nephrologist who's really been prescribing the medications for the kidney disease, and for example, you might be having a problem with those medications, then it might be, you know, more appropriate to speak to the doctor who's prescribed those medications. So it really varies depending on the relationship you have with your doctors and how involved they are specifically in your care? It's a very difficult question to answer. Oh, question. Okay, yes, go ahead.
I just had a question. Just for the kidney, I wonder if there's any relation between another medication for lupus and the kidney. Just because, at one point in your life, you don't take any medication, and all of a sudden you've got 10 or 25 medications you put in your body that again are not natural to your body. And the kidney is a filtering system. So I'm just kind of wondering, has there been any studies done?
So if I'm understanding the question, are medications actually causing kidney problems? Is that, well, certainly they are well known to do that. And as you said, many medications go through the kidneys. So many of our medications do have possible kidney side effects, and we always have to monitor that. So it's not an automatic that if a person who has lupus develops a kidney problem, it's one of the things we have to sort out. Is this in fact lupus, or is it medication related, or is it something completely different? Because unfortunately that can all be the case. However, I think Deb was talking about, if we suspect lupus involvement, we generally get a kidney biopsy, and that's one of the reasons for it, because you can clearly see the difference there between an autoimmune attack on the kidney that is lupus versus medication toxicity. But certainly no matter lupus or not, we always have to watch out for kidney side effects of medications.
Okay, we have a question specifically for Dr. Levy, and that is, do you find that children get misdiagnosed as going through puberty or growing pains when in reality they may have lupus-associated arthritis?
So, most children who have arthritis who we see have juvenile arthritis and not lupus. So for us, I guess there's a couple things. When we see a child who has arthritis, when they are referred to us, we do this ethnic profiling that I was talking about earlier, and we look at the age of the child, and we look at the gender of the child, and we look at the distribution of how the arthritis is and what joints it is, and the ethnicity of the child as well. Because sometimes, as Christine was saying, they may just have arthritis and nothing else, and it may in fact be lupus. And we'll see that over time, or we'll see that if we do specific tests. So there may be a child who's referred as juvenile arthritis who in fact has lupus, and I think we're pretty good at figuring that out. It's the getting to us in the first place that may be the problem, and I think that's really the question. So there are a lot of adolescents in the world that have joint pain, and sometimes joint pain can be just that, joint pain, and it's not arthritis and it's not lupus. So we do see a lot of children and adolescents who have joint pain and fatigue who really don't have arthritis and don't have lupus. I don't know how many we're missing, because that's that black box, that denominator. We don't know. But chances are, if they continue to have joint pain and fatigue or any other symptoms, and they return to their family doctor or their pediatrician, the family doctors are uncomfortable on the whole with joint pain in adolescents, and they do refer them to us. So are there kids who are missed? Sure. But I think it's fewer now than in the past.
So just following up along a little bit in terms of the genetic theme and markers, somebody has asked, are there genetic markers specific to lupus?
There's a good, yes, many. There is no single gene abnormality that you need to have in order to have lupus. And so there's no single marker. It really is, there's many genes that have been implicated in lupus. And most of these, it's not that they're defective genes, it's most of these are immune response genes. And a person's particular combination of immune response genes plus the environmental stuff that we touched on in terms of everything from toxins but to health-related behaviors to emotional stressors, those sorts of things, on top of the genetics will bring out clinical lupus. And so it's not a single gene that we can look for. When genetic studies are done, there are many, many different genes that are involved. There is certainly a genetic background that is, it is a genetic disease in that sense, that there is a genetic background that's required to get lupus, and we do see a little bit more lupus in some families. If you have a family member with lupus, there is a higher risk that another family member will get it, but it is not a hugely clear risk. It's a predisposition more than anything else, is the best way to put it.
I will add something to that. There's a very small group of people who have lupus, very small, that have what we would call a monogenic form of lupus. So monogenic would imply one gene. So there's one gene that determines the color of your eyes, one gene that probably determines whether your hair is curly or straight. For 99.9% of people who have lupus, there is no one gene that determines whether or not you have lupus. But in that very small group of people, there is. And that is not really necessarily the lupus that everyone else has. And these are generally children who present age 5 or younger. Or there's 2 siblings in the family who both showed up under age 10 having lupus. And their lupus may be very severe and have very specific clinical features. And we do have a number of families who we have identified a single gene that gives them their lupus. They may have other things though as well, other immune problems, and not just lupus.
Any further follow-up questions on that? We do have one other genetic type question. Don't know if anybody in the panel feels comfortable addressing the microbiome and its potential link to lupus. I don't personally feel I'm up on that literature and don't feel I can address that. I don't know if you do, Linda?
I think they've certainly linked it to things like ulcerative colitis, different kinds of colitis.
Yes, this is what the person indicated.
Yeah, that it's become increasingly known that the microbiome has huge effects on obesity and different conditions, possibly MS. But I don't think I haven't read anything about it as far as lupus specifically.
Yeah, there's no data yet. I know there are a lot of ongoing genetic studies. It's not to say we're not looking at genetics. Some of them do include some microbiome investigations, but I think to date, now we don't have any information in that world.
While we're talking about diagnosis, I'm wondering, Dr. Clarke, if you can explain the difference between lab work that a family doctor may order if a patient comes in complaining of arthritis, fatigue, perhaps has a rash, compared to the lab work that a rheumatologist in Alberta would order.
Right. So there may not, is it the Mitogen lab you want me
Yes.
to? Okay. I was wondering why you're. So I believe, and you can correct me if I'm wrong, so in Alberta, there are, certainly in lupus, people have certain antibodies, and that is really what's responsible for them having lupus. In Alberta, there are sort of 2 labs, certainly in the Calgary area, that can look for those antibodies. There is the Calgary Lab Services, and I believe if you're usually when the family doctor orders the lupus antibodies, it would be Calgary Lab Services doing it. Then also in Calgary, there is a lab at the university, which is run by Dr. Marvin Fritzler, and they also do lupus antibodies. They do a little bit more than the Calgary Lab Services do, and so I don't think the family doctor would necessarily be usually accessing the University of Calgary lab, right?
Correct.
Right. So certainly, if a patient comes to see me, referred by their family physician, will almost always have had the antibodies, the lupus antibodies, or at least some of them looked at by the general labs in Calgary. When they come to see me, I would order some more antibodies that certainly the family doctor wouldn't necessarily order, which would help me understand lupus a little bit more. perhaps be a little more definitive in making the diagnosis, or perhaps look at antibodies that can make the blood clot more easily that the family doctor may not necessarily look at, and would help people who are looking after lupus more regularly understand whether or not this is a definite diagnosis of lupus, and understand a little better how we should plan this treatment for the patient and plan a course going forward. So I think that that's really the best answer without getting into the specific autoantibodies.
Could I just ask a question, follow up on that? So is there a scenario where in the family doctor's office, if I ordered the lupus antibody and it was negative, and then because I suspected lupus still, I sent them to you, would there be a difference in the test that they might get that would help?
Yes. So there may be a difference in the testing. I won't get into the fine details here, but there may be a difference in testing. And of course, we think about 5% of patients with lupus may never have an anti-nuclear antibody during the entire course of the disease. So we may make a diagnosis of lupus, not often, but we may make a diagnosis of lupus and treat the patient as if they do have lupus, even if they don't have a lupus antibody. So yes, there are circumstances where we do make that diagnosis. Right. Well, I'm very much involved in a research context at the University of Calgary. So I do run them in both labs because I'm interested in the comparison, and I'm doing some research looking at the different labs. I'm not sure that having the family doctor do that is a wise decision, because there's a lot of interpretation that goes on, and it's very, it's somewhat, you really need to be very familiar with the disease to really understand if there's any significance to some of these antibodies. And some of these antibodies, we don't really know the significance of them yet, and some of the research that I'm doing is looking at the significance of some of these antibodies. So I'm not sure in a general context, it's worthwhile having them looked at in both labs.
And I would think that a family physician wouldn't be able to interpret those results really. So if you saw your family doctor and they did a test and they said, well, it's negative for lupus, but you were still having significant arthritis, for example, I would think you would still be referred to a rheumatologist. I'm amazed at how the testing has exploded. There's so many things. Whenever I get a consultation letter from a rheumatologist, there's so many tests I've never heard of, that I wouldn't even want to try to interpret those. So.
And I mean, we're still grappling with the significance of many of these antibodies that Dr. Fritzler runs in his lab. And so certainly this is why we encourage our patients to participate in the CANIAS registry and participate in research, so we can learn more about these antibodies and whether or not they're going to help us diagnose lupus earlier, or whether or not they're going to help us pick out patients who may have a particular type of disease and may be treated differently. So it's not only the family doctors. We also are, always challenged by questions in terms of how to best manage patients with lupus and best interpret the lab results. So that brings us to another question. It's a good segue to another question. And in fact, two people asked this. And they said, what about if your rheumatologist is not involved with CANIAS, is not a CANIAS participating site? CANIAS, of course, for those who may not have been here earlier this morning, is a Canadian network for improved outcomes in lupus. And this is headed by Dr. Christine Peschken. And there are many sites across the country. Calgary is one of the participating sites. And so we're actively involved in recruiting patients for research and collecting both data from the patients and also storing blood to learn more about different questions involving lupus. So, the question is, if your physician is not involved in that, how can you participate in the research?
That is difficult. I mean, one option is going to be different from every site. I mean, because Anne, for instance, here in Calgary, runs the site. It could be an option, but this is up to Anne, for patients who sort of a shared care model, a little bit like what Deb was mentioning earlier, that once a year you see Anne, as the lupus specialist, but otherwise you see your usual rheumatologist if that's going on. And I don't know that I would, I mean, we were always trying to get more Canios sites, but I think if you're in a center where there is a Canios site, that would be the logical thing to do, and I suspect that, you know, signing Ann up here, but I would be very happy to do that.
Yeah, I mean, certainly in Calgary, you know, the rheumatologists are extremely collaborative. So certainly, you know, if you're being seen by a rheumatologist who's not me, and I don't recognize many faces in the audience, so I presume you're all being seen by different people. You know, if you mentioned that you'd like to be involved in the research and you'd like to be referred to the lupus registry at the University of Calgary, and then I would see you once a year, basically. So I wouldn't take over your care at all. You'd still continue your care with your regular rheumatologist. I wouldn't be involved in your care, but I would see you once a year. You'd become involved in the Canios registry. So then if, for example, we were involved in a clinical trial, so for example, a new drug came along for lupus, and you know, it's not yet approved, the studies haven't yet been completed, but we're doing some research to see whether or not patients who get the drug versus those who don't do better, then I would say, I'd look at the patients in my registry and say, you might be a good candidate for this drug. And then I would contact you and explain the study and say, would you be interested in hearing more about this drug? So, you know, it gives you an opportunity to potentially have access to new drugs before they actually become approved for general use. Now, that being said, not all of the drugs, and in fact, many of the drugs that have been assessed in clinical trials have not been successful in lupus, so they don't actually become approved. But it is, you know, Benlysta, which of course, as you know, was approved for the treatment of lupus in Canada in 2011. I mean, you know, we were involved, when I was at McGill, we were involved in the original trials of Benlysta. So it's through the patient's participation in these trials that we could see that this drug, in fact, was beneficial, and this led to the approval of the drug in Canada. So certainly participation in clinical trials is very important if we're going to be able to have new drugs approved for the treatment of lupus. Any further questions on that particular area, or should we move on to some other questions? Okay, so this is just a general comment on I have stable, so it says microscopic hematuria, so what that means is, you know, when my physician does my urinalysis, I have blood in my urine. I can't see it, but you know, certainly under a microscope it can be seen. So, you know, is this something that's concerning, the presence of stable blood in the urine?
So, you know, I can't answer on an individual basis, but we know from all the studies done now, and we work very closely with our nephrologists, with our kidney doctors, that if you have lupus nephritis, so inflammation in your kidney caused by lupus, and it's treated well, and there's minimal protein, there may be persistent hematuria. There may be that blood that we see every single time, and we may forget that we've seen it before, and we may say it to our patients, oh, you know, you have a little blood in your urine. And we may sound like we're just sort of blowing it off and saying, don't worry about it. All the studies that have been done so far have shown that it's kind of one of those things that we don't worry about on its own. And it hasn't been shown to worsen the long-term outcome. But I can't answer on an individual basis. It should be something that is thought about, but for many people who have had lupus nephritis, they may have some ongoing little bit of blood in their urine, maybe forever.
But I certainly would say that in general, that as a lupus patient, you really should be having a urinalysis done at least once a year. So if that doesn't seem to be part of your ongoing care with your rheumatologist or your family physician, that's perhaps not the best way to be managed. So I would ask the question, you know, you're not checking my urine once a year. Is there a reason for that? Because certainly there's been recent guidelines published, I think Christine mentioned them earlier today, about Canadian guidelines about the assessment and monitoring of patients with lupus, or diagnosis and assessment of patients with lupus. And certainly regular urinalysis is important in the care of patients with lupus, whether or not you've ever had kidney disease.
And I'll just say it's really a rule out situation too, right? Because the first thing that somebody would want to do is review your medications that you're on, make sure you don't have a urinary tract infection. But a lot of medications, like if you're taking a lot of anti-inflammatory pills because of your arthritis, that can cause blood in the urine. So it's sort of rule out things that are treatable and then, monitor for other changes.
So I guess in that vein, somebody asked a question is whether is bladder cancer risk increased in patients with lupus? So perhaps I can answer that first, since I've done a lot of work looking at cancer and lupus. And certainly there really is not much evidence to show that bladder cancer risk per se is increased in lupus. However, we do know that in patients who've received large doses of cyclophosphamide over the years, there certainly is increased risk of bladder cancer has been observed. So certainly in that circumstance, there is a concern. So cyclophosphamide used to be used in much higher doses to treat lupus nephritis, probably about 10 or more years ago. Nowadays, with the use of mycophenolate, Cellcept, or Myfortic, many fewer patients, certainly in the adult world, and I suspect in the pediatric world, are receiving cyclophosphamide. And patients who are receiving it are usually receiving it in lower doses than what we used to give 15 or so years ago. So it's become less of a concern, this high-dose cyclophosphamide and the risk of bladder cancer. So, on to a completely different topic. Somebody's asked, any recommendations for the treatment of lupus fog? It's a very difficult question.
It is a very difficult question. It's almost a universal concern, I think, amongst adult patients. I don't know how you experience it with your pediatric patients, that most patients find that their concentration, their memory, their executive functioning, and I mean, this has been demonstrated in formal testing and even with MRIs now, so this is real. Do we have good treatment for it? I would say no. I mean, we need to optimize lupus treatment overall if there's other areas of active. All of the things that, improving sleep, and we know that lupus fog gets worse if you have a lot of pain, if you're not sleeping. All of those things will make it worse, so trying to improve those things may help. Beyond that, sometimes the best that I can do is I try to reassure people this is not a sign of early dementia. This, it is, which is really important. I mean, a lot of people come in and they think, they're 40 years old and they think they're on the road to Alzheimer's or some equivalent of it. And it's really important to reassure them that this is not the case, that it is, unfortunately, it's a stubborn symptom, but it is generally not progressive beyond, fluctuations depending on overall health. That's about as good as I can get with it.
Yeah, and sometimes, I don't think you mentioned this, Christine, if patients come in and they're, quite concerned about their memory or they're not working, they don't feel they're performing as well as work as previously, I'll suggest that they have neuropsychological testing done. I, of course, don't do that myself. I refer them to a facility at the University of Calgary where this is done, and this is an extensive series of testing, can last 3-4 hours, sometimes more, but at least at the end of that there'll be a report, and almost universally the report is very reassuring for the patient because it will say the patient certainly is functioning as would be expected given their education, given their circumstances, and there really is no red flags in terms of early dementia. So I often, encourage patients to do that because it can be a measure of reassurance, and it can also serve as a baseline if the patient feels that their functioning is deteriorating as time goes on.
Yeah, I think for us, it's similar. I showed some of the data. We had looked at doing neuropsychological testing for a number of patients, and we do see this as well, which can obviously be difficult if you're going to school every day. It's difficult if you're working every day too. But we really do find if you're optimizing sleep, if we're optimizing how we're giving prednisone, optimizing exercise and, sleep rest, sleep-wake cycles and not napping all the time, we can improve the symptoms. We do neuropsychological testing as baseline if required, and sometimes repeated over time. And there have been trials looking at using a specific drug that maybe activates one of the neurotransmitters. Didn't work. So I don't think anyone's really doing that. There's some push that maybe cognitive training might be useful, and there are specific programs out there that can be engaged, but you need to be doing this program. I think it's several minutes every single day, and it can be quite burdensome, and I'm not sure there's been data yet to show that it's made a significant improvement. But that may be one way that we can improve things.
And I think you also.
Yes, I again just wanted to comment about medications, because with fog, there's certain medications that could definitely make it worse. Typically sedative medications, sleeping pills, people take Gravol for sleep. Those are medications that have what we call anticholinergic effects. Some bladder medications, some antidepressants. There's a lot of medications that can make confusion and fog worse. So one of the first things is should be a review of the whole prescribing.
So I'm going to close with another question that we've received here. But before I do that, are there any other questions from the audience? I apologize if I haven't gone through your specific questions. Certainly you can bring them to the panel members afterwards. Any other questions before I conclude? Chris, Rosemary, are there any other particular issues that you wanted us to bring up that we haven't perhaps touched on?
If a patient goes, so if someone suspects they have lupus and goes to the family doctor, then they could, we would give them rheumatology referral information, and so they would then ask the family doctor to refer to the lupus clinic or to another rheumatologist in Alberta. That would be the procedure to.
You're asking, yeah.
Correct.
Right, so the patient would go to the family physician, and normally if the family physician is concerned, they would write a referral to rheumatology. So in Calgary, almost all of those referrals go to a central site, and then they're basically sent off to the rheumatologist who has a particular expertise in that area, or who has sort of the, earliest opening. So for example, if the referral said lupus, they would often come to me. But of course I can't take all of them. And if it said, urgent, and my next appointment is in 2 months, then, that patient wouldn't be best served by waiting to see me. Now, if the family doctor called me directly and said, look, I have a, new lupus patient, or call the rheumatologist on call and said, I have a new lupus patient, they really need to be seen, then that certainly, the physicians, the rheumatologists then may speak to me directly and say, there's a new lupus patient needs to be seen in the next week, can you see them? So then I might very well be able to see that patient. So it's a little bit of, variable about how it works, but in general, those are the processes. I don't know if you want to comment, because I see it from one end, you see it from the beginning, I see it from the end.
Right. No, I think that's how it works. It's sometimes it's personal contact that the squeaky wheel gets the oil,
Absolutely.
right? So and that goes for a patient too. If they're not happy with how things are, and then sometimes the system can be manipulated.
Yes, that's absolutely what I say to the patient. I may fill in a referral and I may say, okay, you should hear about this referral, or you should be scheduled within a month or two. But I always say to the patient, if you haven't heard within a week or so, call my secretary, because it's so right. The squeaky wheel, gets the grease. Mm-hmm. And don't just sit back and think it's all working its way through the system, because unfortunately that doesn't always happen. Referrals are lost, misplaced, tests are not scheduled. So that's it, be, as I think, as you said, Deborah, be your best advocate. You're your best advocate. Sure. You or your family.
So then if a person has been diagnosed with lupus and is under the care of a community rheumatologist and wants to participate in the research, can they self-refer, or does the family doctor have to make that referral to a lupus clinic?
Right. So in reality, what can actually happen is the individual could actually contact the Lupus Society, and you could put that individual in contact with my research nurse. And then I would see that patient, but again, that would really be for a research visit. I wouldn't be assuming the care of that patient, but I would be seeing that patient and enrolling them in the registry.
So if someone has had the diagnosis and they contact us, we can refer them.
You can to participate in the registry. Now, if they want, ongoing clinical care, that would be a different story. Then their physician would have to refer them to rheumatology, and then they would be, I'd see them for clinical care. So I think the final question that we'll conclude with, which I think is a very good question, extremely good question, and the question is it realistic to wish for a day when we do not require any medications for our lupus? So I will put that out there.
I don't think it's unrealistic. Right now, what I'm telling my lupus patients is that my medium-term goal is that they're on one pill, which is hydroxychloroquine. We touched on that a little bit, sort of one pill once a day. That's my ultimate goal. And this is what I'm telling them, you're taking this and steroids and mycophenolate and all this other stuff. I'm saying what I hope is we can get rid of all this stuff and we can maintain on hydroxychloroquine, which is still not no pills. And part of the ongoing debate about hydroxychloroquine is who is it safe to stop in? We know there are people who in fact do achieve that, who do well and don't need pills long term, and we don't know who they are, and we don't know what the risks are. And that is the subject of both that study that I mentioned, but of many other studies to try and figure that out or treat better so that we can achieve that. And I really hope we do achieve that more often in people's lifetimes here.
And I guess I'll let you have the last word there. But I guess what I would say is certainly in terms of sort of getting patients off their medications, I think the general rule should be nice to get prednisone gone first.
Absolutely.
And then you can get rid of the mycophenolate or the azathioprine or the methotrexate that you may be on, and then Plaquenil would be the last thing. So if you see your doctor getting you off the Cellcept and keeping you on the prednisone, that wouldn't be the way we would normally proceed.
Yeah.
And certainly if you see your doctor getting you off the Plaquenil, now not because you have eye problems, but just stopping the Plaquenil and keeping you on the prednisone, that would absolutely not be the thing to do. Absolutely not. So I think those are general rules about tapering down lupus medications.
I think I have to agree completely. When we're talking with teenagers, again, that teenage brain that doesn't see the future, can't perceive the future, can't perceive mortality. Everyone thinks they're invincible when they're a teenager, and that's fine. We understand that. We really break it down to the minimum medications, not numbers of pills, but numbers of medications, and what each of them is for. And I tell them, this Plaquenil one, this is like the vitamin. You take this one as your daily vitamin. It's the prednisone that I'm worried about, but you can't stop it cold turkey. This is the one we're going to aim to stop first. Then this other one, which is mycophenolate or azathioprine or methotrexate, if they need that, that's the one that would go second, but it's going to take a long time. Now, I don't think 2 years is a long time in my mind, but if you're a teenager, 2 years is eternity. So I tell them this is a long time. And so if they start with that, they get used to it after a while, and they hear me say things over and over again. So if you're ever unsure of how long you're going to need a medication, we can never tell you for sure, but we might be able to give you some idea. Weeks, months, years. And every time we start a new medication, that kind of dialogue should happen, and it should be clear. Is this something I need for days, weeks, months, years, the rest of my life? I think that's a reasonable thing to ask. You can't say, well, is it going to be exactly 6 weeks? Because then I need to be off it. Because again, you can imagine the teenager is very concrete. Well, you said I was going to be off in 6 months, and it's 6 months and a day, so I just stopped it. It's a problem. It happens all the time in the clinic. All the time. These are not antibiotics for your pneumonia or for your strep throat. This is not, a 2-week deal. So, you're right. You have to ask these questions. And in our mind, I would love to get everyone off all their medication. it does not bring me any joy to have you on prednisone and mycophenolate and everything else. And so I would love for that day to come. I would love to be out of a job because nobody needs me, but we're not there yet.
Yeah, I guess, the other thing I would say is, we certainly do talk about the benefits of Plaquenil, and increasingly we are recognizing more and more of these benefits. But it's very important, particularly if you've been on the therapy for at least 5 years, to absolutely see an eye doctor once a year. I know you all know this, and I know, and your rheumatologist should be asking that question every time they see you. Have you had your annual, eye assessment? But that is absolutely critical, so that if there is any problems related to the Plaquenil, it can be picked up early. So certainly the annual eye assessment after 5 years of therapy, if not before, is certainly quite important.
Not to be a downer.
Yes.
but it is a multi-system disease too. So
yes,
and each system that's involved is going to have their own specific needs. If you have cardiac disease, or high blood pressure, or kidney disease, then there's going to be other things that are going to be needed on an ongoing basis for prevention, really, of events with that. So, it's always a good idea to have reviews and be on the minimal medication, but with a chronic illness, multi-system disease, there's always going to be something that's necessary.
we fulfilled your expectations of the panel.